Good afternoon. I'd like to welcome everyone to our web-based seminar, Changing the Conversation, Human Rights and the Power of Words in Tuberculosis Care. My name is Jane Carter, and I'm an associate professor at Brown University, as well as the president of the International Union Against TB and Lung Disease. The union has made multiple efforts this year to address the issue of language in all our publications and conference materials. And so on behalf of the union, I just want to thank the organizers from GTBI for asking me to be your moderator today. And I also want to thank Heartland and GTBI in moving this issue forward with this webinar. The Global Tuberculosis Institute is on social media, and I hope you'll connect with us on these sites for the latest updates and resources. So let me hand over the microphone to our first presenter, Michael Watson-Frick from TAG.
Great. Thanks, Jane, for that introduction. It's really nice to be here today online talking to all of you and with Barbara and Jigna, too, about human rights in the context of the TB response, and in particular how human rights relate to a very specific goal of a world with zero TB, or what's more commonly referred to as TB elimination. And so that's where I wanted to start today, was with the goal of TB elimination. And it was officially endorsed and picked up by the World Health Organization last year in what they're calling their NTB strategy. And the WHO is defining TB elimination as a 95% reduction in TB deaths by 2035, a 90% reduction in TB incidence by 2035, and making sure that by this time point, no person or family has catastrophic spending due to TB diagnosis or treatment. And for all of us in the United States, where TB elimination has been a stated goal since the 1980s, none of this is going to sound particularly new or unfamiliar necessarily, but it was only recently that TB elimination became a global goal in the same way that it's been a goal in the United States for over 2 decades. And what I want to point out here is that the WHO, in outlining how we're going to get to TB elimination, has said that we really have to achieve things in 3 different pillars, the first of which is integrated patient-centered TB care and prevention, and I'm going to talk about patient-centered care toward the end of the talk. The second pillar is looking at bold policies and supportive systems, and the third is looking at intensified research and innovation. We're developing the new tools that we need to diagnose and treat TB. And what's important to notice here is that these pillars are resting on the realization of several other things, and a part of this foundation for the NTB strategy is protecting and promoting human rights, ethics, and equity. So human rights are very much at the center of the NTB strategy and our road to TB elimination efforts. So to take a step back from TB specifically and just talk for a minute about human rights more generally and ask, what are human rights? They're described as universal and inalienable. That is, that all people have rights by virtue of being human, and they apply to all of us equally without any kind of discrimination. I think there's a tendency sometimes in the public health world and beyond to think of human rights as these very abstract ideals that exist high in the sky and are a little bit vague. And actually, the opposite is true. They're incredibly defined, particular, and detailed in their conception. And that's because human rights are defined by international law, or a series of treaties and conventions that have been drafted and negotiated by governments working together under the auspices of the United Nations system. And so it's really in international law that we find the definition of human rights, and they're considered to be a kind of legal instrument. They're primarily concerned with the relationship that individuals have with their governments. And so under a human rights framework, it's individuals who hold rights and can make claims on governments who then have the obligation to respect, to protect, and to fulfill human rights. And when we say respect human rights, we mean that governments themselves can't take any action that would violate a person's human rights. Protecting human rights means that governments need to ensure that other actors, whether they're individuals or corporations or other states, don't take any action to violate a person's human rights. And fulfilling human rights means that governments need to put into place the policies, supportive environments, and systems that people need to be able to exercise and fully express their rights in society. The rights themselves are civil and political, and this branch of human rights should be very familiar to Americans. It's basically what we find in our Bill of Rights or within our Constitution, and refers to things like freedom of movement, freedom of assembly, freedom of religion, etc. But some rights are also economic, social, or cultural by nature. And this is what I'm going to focus on today in the context of tuberculosis. And here, I think the most relevant right for us to be talking about is the right to health. So when it comes to TB, the right to health is the place that we tend to start. It specifically is referring to the right of everybody to the enjoyment of the highest attainable standard of not just physical health, but also mental health. And the right to health is something that is first articulated within the Universal Declaration of Human Rights, drafted shortly after the Second World War. And it entered into international law and binding treaty force through the International Covenant on Economic, Social, and Cultural Rights, where it's found in Article 12. But the right to health also appears in many other different treaties and conventions, including the Convention on the Rights of the Child, the Convention on the Elimination of All Forms of Discrimination Against Women, and in a document that's called General Comment 14, in which the High Committee on Economic, Social, and Cultural Rights really laid out in detail an interpretation of what the right to health means and what it applies to. So this is all to say that when you refer to the right to health, you're not going out on a limb. There's a huge body of jurisprudence and public health experience behind the right to health, even though I think I probably should point out here that while most governments have ratified and signed the International Covenant on Economic, Social, and Cultural Rights, where the right to health is really first introduced, the United States remains one of the few governments that has not signed and ratified this convention, although we have signed and ratified others that the right to health appears in. So as Americans, we are operating in a slightly exceptional environment when it comes to the right to health. And just as we understand that health itself can't be isolated from other social and economic conditions, the right to health doesn't exist in a vacuum. And human rights are very much understood to be interrelated with one another. And so on this slide, I've just listed several other human rights that I think closely are implicated by the tuberculosis epidemic. So within the International Covenant on Economic, Social, and Cultural Rights, Article 7 discusses the human rights that people have with regard to occupation and labor. And within Article 7, there's mention that people have the right to safe and healthy working conditions. We know that TB is, of course, very closely related to occupational and working life, whether you're a gold miner in South Africa, a tin miner in China, or even a healthcare worker. All of these groups are experiencing higher exposures to tuberculosis that are patterned by their work environment, particularly in the absence of infection control. So when we talk about TB, labor rights are definitely at the forefront of our attention. There's, of course, the right to health itself in Article 12, which further specifies that people have the right to expect the prevention, the treatment, and the control of diseases. So that should sound very familiar to us. Within General Comment 14, the Committee on Economic, Social, and Cultural Rights articulated what's sort of been called a right to information, or noting that people have the right to access health-related education and information that they need to either protect themselves or to make informed choices about their diagnosis and treatment. And then there's Article 15, which says that people have the rights to enjoy the benefits of scientific progress in its applications. And this is particularly relevant for the research context, noting that to the extent that scientific research develops better drugs, diagnostics, vaccines, treatment modalities, and other technologies to respond to TB, people have the right to enjoy the benefits of such scientific progress and medical advancement and its application through health systems. I'll just note that Article 15 on scientific progress is a lot less defined, normatively speaking, than Article 12 on the right to health, although it's an active area of interpretation and scholarship right now. And for the rest of today's presentation, I'm going to be focusing mostly on the right to health, but I think it's important just to keep in mind that these other rights are existing in the background alongside it. So the biggest body of work to date on the right to health is in the response to HIV/AIDS. And despite TB and HIV having a famously close relationship with one another, we hear about human rights and TB much less often. But actually, I think there has been quite a bit of work done on human rights and tuberculosis, and not all of it is recent. So, over a decade ago, in 1999, Paul Farmer, writing in the American Journal of Public Health in an article titled "Pathologies of Power," described his experience working on TB within the Russian prison system. And within the article and his observations, he noted that the way prison life was organized, the way that prisoners were kept closely together in small, narrow spaces in the same cells, contributed to the higher risk of TB that Russian prisoners experienced and the very high rates of TB, including some drug-resistant TB within the Russian prison system. So in Farmer's words, he says that increased TB risks should themselves be seen as a violation of rights within the prison context, that TB has become a form of punishment almost. And he, of course, noted that this is due to the things that we recognize, such as overcrowding, ineffective infection control, tardy diagnosis, and ineffective or interrupted treatment. And rather than recognize these factors as merely health-related, he was making an argument that they should also be seen as a kind of human rights violation in themselves. Farmer's experience in the Russian prison system came at a time when MDR-TB was not always routinely treated in countries or in all settings, under the argument that, if we focus on DOTS and focus on treating drug-susceptible TB, MDR will resolve itself. We can prevent it from developing further. And a lot of people at that time were making an argument that MDR is too expensive, too complex, too costly to treat in resource-limited settings or in complicated situations like prisons. And at the same time that this argument was being made internationally, Farmer, within the prison system in Russia, was hearing from people working within that system that many prisoners with drug-resistant TB were refusing their treatment, which oftentimes was not an effective therapy. They were either kept on first-line regimens or on a monotherapy regimen in which a single drug had been added to the failing first-line regimen. And so Farmer was asking the prisoners, is it true, are you refusing to take your therapy? And one of the prisoners, according to Farmer in the article, interrupted him to say, it's not true. We want to take treatment, but we want treatment that can cure us. So in saying that, this prisoner was making a human rights argument or claim, whether he knew it or not. He was essentially saying that his lack of adherence to TB therapy was not because he didn't understand his condition. It was quite the opposite. It was because he understood his condition all too well. He knew that the treatment he was on was not making him better. It was not curing him, and he wanted access to curative therapy. So this is, I think, really where the story with TB and human rights started over a decade ago with Paul Farmer in Russia. But I think there's also been this sort of tendency in recent years to think of human rights and TB as a rediscovered area for work. And so it's a story that does need to be retold to a certain extent. A couple of years ago, the Global Fund to Fight AIDS, TB, and Malaria published an information note on human rights and TB. And they noted that because of the way TB is closely associated with social inequality, poverty, because of the way it mostly affects vulnerable populations who may have poor baseline access to health services, it very much is related to human rights concerns and considerations. And there's a need to break out of a more biomedical context in which we see TB as biomedically driven to recognize the social inequalities that drive the TB epidemic and to really put people with TB at the center of the health response. And I think certainly the current state of the TB epidemic has created no shortage of issues that, one, raise human rights concerns, and two, are open to human rights-based solutions, whether it's the quality of treatment for MDR-TB, which as the picture here indicates, requires upward of 15,000 pills, daily painful injections at the beginning phase of therapy, and side effects that range from vomiting to suicidal ideation to deafness, or whether it's the fact that globally over 80% of patients with MDR-TB receive no treatment at all, and many are put on treatment waiting lists, a fact that I think can really only be described as a crime. So we have a lot of human rights issues to focus on, but one point that I want to make here is that human rights are not just ends. They're not just things that we need to achieve or protect. Human rights are also means. That is, they are tools that the public health practitioner can use when responding to TB. And so I really want to talk today about human rights in their capacity as tools that public health programs can use. And starting by just talking generally about what human rights can offer the response to TB. I've borrowed most of these points from a lawyer named Brian Citro, who has started to do a lot of work on TB and human rights. And he acknowledges from the outset that human rights, and the right to health in particular, must be used as tools to increase access to TB testing and treatment. But he also thinks that focusing on human rights allows us to see the social determinants and drivers of the TB epidemic and to break out of a strictly biomedical approach to facing TB. So a rights-based approach acknowledges the underlying social and economic determinants of TB, the social determinants of health, in other words. It would also articulate the rights of people living with and vulnerable to TB, so not just those people who have TB, but also those who have greater vulnerability to acquiring TB or having reactivated latent TB infection. And a human rights-based approach would also empower and encourage people to claim their human rights. At the same time, rights-based approaches to the TB epidemic are going to clearly establish the legal obligations of governments and other actors, such as drug manufacturers, to ensure that good quality TB testing and treatment are available and accessible to everybody. So talking about a rights-based approach to TB is partly recognizing what drives TB, partly empowering people with TB to claim their rights, and partly clarifying the obligations of governments and other actors to respond to the TB epidemic. So that is talking more generally, but then if we look and ask the question of how human rights can be put into practice within TB programs themselves, I think that there is a lot of room for discussion. And I'm going to talk about each of these 3 points, embracing patient-centered care, speaking of rights alongside responsibilities, and combating stigma and discrimination. I'll talk about each of these in turn, and I know that Jigna and Barbara are going to dive into the details of some of these as well. But I thought that before getting to the good examples, we could maybe start with a negative case example that illustrates the opposite of a rights-based approach to TB treatment, and is perhaps a warning of something that we should always seek to avoid in terms of delivering TB care. So this is the example. It's the testimony of an XDR-TB patient in South Africa that was given to a TB researcher named Amrita Daftry as part of a study that she was conducting. And because we're on this webinar format, I'll go ahead and read it out loud to you all, and then discuss a couple of the points that come out of this. The yellow card came to my house and asked the surname. She, meaning the nurse, came out and put the gloves on, and it was clear that this is bad. When she came inside the house, everything was special and urgent. My child said, "We learned about this at school. It's better when it's MDR. When it's X, it's the last stage. That is when you are about to die." I am sick of this vehicle because people knows about it. They were standing on the road, putting these things, meaning the masks, on, and writing names on the pill bottles. They don't even come in the house. They ask while they are outside. My son just ran away. He doesn't want to sleep there. It's because they told me about XDR in his presence. So the first time I read this vignette, I was really heartbroken about what was happening to this woman with XDR TB in the course of her treatment. And just within the space of these few sentences, I think there is a lot that comes to the foreground in terms of thinking about human rights in this situation. The first thing that I think about is the fact that the disclosure of the diagnosis of XDR TB was not made with the individual in private. It was given to her in front of her family so that her son learned it was XDR TB, something which he interprets based upon the knowledge he's received at school as a kind of death sentence for his mother. So disclosure of diagnosis without necessarily having the patient's permission to disclose in front of others. I think it's also clear that the treatment here is being delivered in a way that is maximizing stigma among both family and neighbors. The fact that the healthcare workers are afraid to enter the house, that they park their car, right in front of the front door and it's recognized by others. They put their masks on outside in public. They're writing the patient's name on the pill bottles outside of the house. There's a real sense that this diagnosis is being broadcast to anybody who might be nearby. There's also no sense from this patient's testimony that she's receiving any kind of psychological or psychosocial support for processing this diagnosis that she's just received and the reaction of her family to it. And there's also no sense of patient education or attempts toward treatment literacy. It's not clear that XDR TB has been explained to her as something that is more than terminal, in the words of her son. And so instead of harnessing social support, the way the treatment is being delivered has really positioned the patient as a kind of threat to her family and her community and created this situation where her son runs away from home. So I think this is kind of a worst-case scenario, and it's very possible that we can all think of scenarios that are worse than this one or perhaps equally as bad, and it gives us a starting point to move away from through using a human rights-based approach. So the first way that human rights can be mainstreamed into individual patient care that I want to talk about is embracing approaches to care that are really patient-centered. And here I want to point out and hope that you all will recognize that many human rights principles are shared with principles of patient-centered care. So in the green boxes, I've listed principles that are commonly referred to as like human rights principles when we talk about rights-based approaches to health. That is, a rights-based approach should be participatory, it should be non-discriminatory, it should build accountability, it should be transparent, and it should involve the exchange of information between people who have knowledge and people who need to acquire knowledge in order to make some kind of decision or take some kind of action. And on the right-hand side of the slide, I've listed different ways that people have defined patient-centered care through various components. So delivering care in culturally competent ways, which oftentimes involves the active participation of the people that we're seeking to treat. Or supporting patient education, such as treatment literacy, which of course would involve some transparency, the exchange of information, and by educating patients, we also create a kind of accountability as well, both for ourselves and for the patient him or herself. Some people have talked about patient-centered care as decentralizing care and limiting periods of institutionalization and isolation. This is going to be relevant more clearly in a minute with another example that I'm going to talk about. But patient-centered care should also reduce the cost of treatment and recognize that costs themselves can be financial, psychological, or even social. And then, of course, actively listening to patients and giving them a voice in decision-making is key. One of my mentors said that human rights-based approaches to health service delivery start with active listening, and I think that patient-centered approaches to care start with active listening as well. So if you're talking about patient-centered care and striving to achieve that, you're really working within a human rights context already. There is a guide to help us with these efforts. There's the charter, the TB Patient Charter, which starts to lay out rights and responsibilities. I think that this document is a good start. I like it, but I have to tell you that in reading it, it made me recall what the Indian writer Arundhati Roy said, which is that around the world, the poor have few entitlements but plenty of duties, which is to say that this patient charter has much more to say about responsibilities than it does about rights when you read the document. And it particularly focuses on the responsibilities that individual patients have. A human rights-based approach would, of course, recognize that it's individuals who hold rights and it's governments who then hold the responsibilities or the obligation to respect, protect, and fulfill them. So I think there's something about this guide that is a little out of balance from a human rights perspective, where there's a greater emphasis on the duties that patients hold and less emphasis on entitlements, and almost no mention of governments and their responsibilities and obligations to respect, protect, and fulfill the rights that TB patients have. So I think this is a good start, but I think it doesn't quite take us all the way home if we're working within a human rights framework. And I do just want to issue a caution, which is that, I think we need to be careful to make sure that patient-centered approaches to TB care don't mean recentering all responsibility back on the person with TB. And to ensure that that doesn't happen, I think human rights are a good place for us to start. So one question I'm asked all the time when I talk about rights is, well, what happens when rights conflict, either with other rights or with responsibilities that we have and that are important? And this is usually brought up in the context of limiting individual human rights in the interest of public health or safety. And in the context of TB, we talk about this most often when it comes to detainment of TB patients to protect the public and others from transmission. And so, people ask me, well, what's the human rights response to this kind of conflict? And in this situation, human rights practitioners turn to a document called the Siracusa Principles, which outline when it's justified to limit human rights in the name of a greater public good. And the Siracusa Principles outline a number of considerations and criteria that have to be met. The first is that any kind of restriction on rights needs to be judged as absolutely necessary. That is, you've exhausted all other means, and the only thing left is the restriction. The restriction also needs to be proportional and to the potential harm. In other words, don't overreact and overreach. The restriction also needs to be temporary. You can't restrict a right indefinitely. So there needs to be a clear timeline behind when the right is going to be restored. That is, we're not going to detain somebody until the end of their days. If we detain somebody for treatment, we have to have a plan to end the detention at the time that we make the detainment. But the Siracusa Principles also say that restrictions on rights need to be non-discriminatory and non-arbitrary. That is, we can't single out some people or some groups of people while not applying the restriction to others who might be implicated, given the context. And we also need to make sure that restricting one right can't be used as a justification for limiting all rights. So taking away freedom of movement under forced detainment is not also an excuse to then not pay attention to the patient's housing needs, their food needs, their right to life, their right to psychosocial support, and other critical enablers of successful treatment. So I think ultimately the Siracusa Principles are a way to sort of shift the dialogue and shift our attention and recognize that people with TB don't just have sick bodies that may or may not pose certain public implications. They also have rights-bearing bodies. And so at the point where we approach somebody with TB, we also need to be thinking about their rights and not just their illness. So in short, how do human rights resolve these kinds of tensions? The answer is in dialogue with the criteria outlined in the Siracusa Principles, all of which I think could easily be picked up and used by public health programs. I also think it's possible that under a rights-based approach, we're going to have to tackle stigma and discrimination. And part of this is going to include avoiding stigmatizing language. Barbara is going to talk about this a lot more, and I don't want to steal any of her thunder. So I'm just, on this slide, sort of introducing the fact that a lot of the words that we traditionally use in TB are quite discriminatory and stigmatizing by nature, but that there are alternatives that have been suggested that I think we should begin to mainstream into our daily practice. And for more information on this, you can look at a couple of publications. One recently in the British Medical Journal, and then the original one published in the Journal of the Union in 2012 by Zachariah and colleagues. And I also think part of fighting stigma and discrimination is going to require avoiding the politics of fear and thinking really carefully about how we message TB to the broader public and to the media. And it's not just TB that's involved here. I think just within the past year, we've seen countless examples of where informing the public has tipped over into sort of terrifying the public and turning people who might have a particular pathogen or illness into would-be terrorists. And we've seen this happen with Ebola most dramatically, including the forced detention and detainment of U.S. healthcare workers returning from Africa. We've also seen it in response to the MERS epidemic, most recently in South Korea, and certainly with XDR and MDR TB. So I think a question for us as people within the United States working on TB is, do we need to announce every case of MDR and XDR TB to the media? There are benefits to this, of course, in terms of raising awareness and attention for a critical issue that we feel dedicated towards solving. But I think there are ways to do it responsibly and ways to do it less responsibly. And it's also important to recognize that in certain contexts, the idea of reporting every MDR or XDR case to the media would just simply be impossible. There are so many cases that can't all be reported. So we really are, in a way, in a particularly special and almost lucky situation in the United States in which these cases are the exceptional ones. And they naturally, as a result of that, are going to garner attention, but it makes it even more incumbent upon us to handle that attention in a way that's responsible, that's humanizing, and that doesn't leave somebody with TB out on the line to take a lot of public attention that may not always be positive. And so thinking about raising awareness versus stoking fear is something that doesn't have an easy answer, but I think it's something that we need to tackle together. And I'd be really happy to talk further about it with all of you. Comments or thoughts that you might have. And as always, if there are any advocacy issues, rights-related or otherwise, that you think TAG should be working on, please get in touch and talk to us about those as well. So thanks so much.
Thank you, Mike. I think that's actually been a great introduction in the whole issue of human rights. So I'm going to hand over the podium to Barbara Seaworth, our next speaker on Stop the Stigma.
I want to thank you for asking me to speak. I'm really excited about having the opportunity to discuss our Stop the Stigma campaign. And I really want to start by acknowledging the support that TAG gave us to carry out this campaign. We probably would have been able to do some of it, but certainly not all of it without their support. So it's really been helpful. For a long time in my work with tuberculosis, I recognized that there was a lot of stigma associated with the diagnosis of tuberculosis, and that stigma really powerfully affected those individuals impacted by disease. But what I didn't know for many years, or failed to recognize, is that the language and the words I use may also be adding to that stigma. Part of that, I want to just step back a minute and note that the guidelines for treatment of tuberculosis in the United States place the responsibility for a successful treatment outcome directly on the shoulders of the provider that is the prescribing physician. However, in the very next paragraph, they make a very strong statement saying that the organization and supervision of treatment needs to be individualized, taking into consideration specific needs of particular patients, and they describe that as patient-centered care, and we've heard about patient-centered care already from Mike, and it's really critical that each of us caring for persons with tuberculosis make sure our care is patient-centered. And that includes making sure that as providers we give treatment that's curative and non-toxic, that respects the individual person that we're caring for and allows that individual to participate as a partner in their care. And if you think of all those things, it really follows automatically that the care we give should be free of stigma, and that includes stigmatizing language. And that means not just myself as a provider doing the prescribing, but the whole public health community and everyone involved in the care of that individual person and in every facet of their care. And if you think about it, it means the DOT worker, the contact investigator, the administrative person signing the individual patient into the clinic, and our public health departments who create products and education relating to tuberculosis. All of us should keep in mind that we need to eliminate stigma from the work we do and from the language that we use. For a long time, I noted that I failed to understand the impact of language, but maybe in the late 90s, it became clear that you could not describe an individual human being as illegal. Persons aren't illegal. And when myself and others became aware of the wide use of illegal in terminology, which often applied to the individuals we were caring for, we decided that this word was something that we weren't going to use and eliminated this word from our vocabularies. Somewhat later, we also recognized that the word non-compliant was a word that placed blame on the shoulders of the individuals we were caring for. And that probably was a result of the document, the TB treatment guidelines, that noted the need for patient-centered care. And we realized that the blame for poor outcomes often had to come back to us as providers, and that it was multifactorial, the reasons that led to poor outcomes. And we needed to stop putting all that on non-compliant individuals. And so we really stopped using this word too. But a real call for change in our language and the impact of stigmatizing language on patients came with this publication from the Union in 2012. And they called for patient-centered terminology that would not be harmful or hurtful to individuals with tuberculosis. And they really singled out 3 words in this particular article. And those words are highlighted here on the page. The words defaulter, suspect, and control. And they offered alternative language that we could use instead of those words. They noted use of those terms was at best inappropriate, coercive, and disempowering, and at worst judgmental and criminalizing. So as Mike noted in his slide, they suggested that instead of using the word defaulter, we talk about a person that was lost to follow-up. Instead of using the word suspect, that we talk about a person with presumptive tuberculosis. Or there are a number of ways you can identify an individual that may have tuberculosis, or that you're evaluating for tuberculosis. And one of the problems that kind of got in the way is people raise the question of, oh, in an abstract, I'm limited to so many words, and it's easy to just write suspect. Well, I think we can all find a way to write our abstracts with just a few more words and back away from that word suspect. Even though it does take a little longer to write my notes, or it may take a little longer or a few more words in an abstract. Suspect is a particularly hurtful word. And then the word TB control. I'm not sure we need it at all, although for many programs it means we're trying to control the disease. Our patients see that word, and their initial reaction is maybe there's some effort to control them as well. And clearly at our first visits, oftentimes we're telling them of all their responsibilities and what might happen to them if they don't adhere to their responsibilities or adhere to their treatment. And they may be given a warning letter or a control letter. And I think we can use language that would be better and have our patients maybe accept what we're trying to do a little better when we can eliminate some of that language from our terminology. Once I read this article, it really made an impact on me. I think it made an impact on everyone that read the article, and I made a personal commitment to stop using the terms that were identified in the article. I stopped using the word suspect and wrote out a longer phrase. But I think, I hope that this helped to eliminate some of the hurt. And as I spoke to patients with tuberculosis, they did note that language was hurtful, and I became increasingly aware of the hurt that language could cause. Again, the word suspect is a particularly hurtful word, and one that individuals with tuberculosis will again and again come to as this is the word that is probably the most hurtful to them. And this is just one of the patients at our hospital holding up a sign as to how he feels about the word suspect. Although this article I do think from the Union Journal had a big impact on those of us who read it, many people didn't read it, and there needed to be an increased awareness, and that happened when civil society called for the retirement of stigmatizing and criminal language from the global TB discourse. This is something that the HIV/AIDS Committee had done years before us, and very successfully, and I think with powerful impact, but hadn't really bubbled to the top in the TB community until this call. And one of the things that civil society did was to write a letter on March 10th to the union, asking them to take steps to retire the use of stigmatizing and criminalizing terminology, noting that language was very powerful, and it was important for all of us to change to language that would be not be hurtful. So only 2 days after the letter was written, it was remarkable. The executive director of the union thanked us for voicing concerns and acknowledged that many of the terms that have been used for years were stigmatizing, and further noted that they were committed to communicating in a manner that embodies respect for all persons affected by tuberculosis. And you heard Jane talking at the beginning of this this webinar about the work that the union has done to change and to make a difference in how language is used within all of their activities. And so this is really, they were just a global leader and amazing partner in this work. I'm a member of the National Society of TB Clinicians, and at the time the letter was written, I was the president of the society. And our executive group decided to support the letter, and we wanted to do more than just supporting that letter. We decided that we wanted to make sure that our society was actively involved in this work to end stigmatizing language. We decided that we were going to send a letter to each speaker at our national conference asking them to avoid stigmatizing language in their presentations. And we were happy to note that this was really well received by each and every one of our speakers. We further challenged the other societies to consider doing the same thing, as well as the overarching group, the National Association of TB Controllers, and the initial response from these groups has been very positive, and we hope to add them to our ranks very soon in firmly supporting this effort. But I asked myself, what more can I do to make an impact and to increase awareness? And I thought this wasn't enough, that we have to get the word out there to local and the people on the ground delivering care. And so I turned to the staff at the Heartland National TB Center and the patients at the Texas Center for Infectious Disease. I knew they would be a way to really think of great ideas and to have the energy to put behind a campaign that would increase awareness. And we knew that even a small group of individuals working with passion and great energy can make a difference and can make an impact. We launched our campaign at the National TB Conference in Atlanta in June of this last year, and we had a lot of enthusiasm, a lot of interest, and you can see this is Heartland's booth at the National TB Conference, and many individuals wanting to know more about our campaign. We started out the day by wearing T-shirts in which we pledged to stop the use of language that was stigmatizing. Each of the members of the advisory committee from our states that are included in the region that we serve also wore these T-shirts and supported our efforts. We asked others to pledge to join us to eliminate stigmatizing language, and you can see on this board here that each individual who took the pledge signed their name, and we put them up on these little ribbons, and that by the end of the conference we had nearly 200 people who had pledged, and we would like those of you listening today to consider pledging, to go to the Heartland website and filling in some blanks and joining us in this effort. And we'd like to see over 1,000 people take the pledge and commit to getting rid of stigmatizing language. Other activities we did were we passed out calendars that showed the pictures of different individuals from the hospital that had joined our campaign and supported us and really worked really hard, and were very enthusiastic about the ability to work on this. We passed out armbands. As individuals entered the conference on the first day, on the big screens at the front of the room were testimonials of persons affected by TB disease who had participated in our Stop the Stigma project. And I felt, and many others agreed with me and mentioned to me and commented, that their stories were very powerful and got the attention of the individuals in the room. But you'll be able to find all of them on our website. I'm going to just click through the slides and let the words of the individual patients themselves speak for them rather than read them to you. So these were the patients' words. We helped them to put them on these cards in a way that would be able to be easily read, but they weren't words that we gave them. They were words they came up with themselves. If you go to our Heartland National TB Center website, you'll quickly see this woman's picture and pop up. And if you click there where it says "We challenge you," it will take you directly to the portion of our website that deals with our Stop the Stigma campaign. And once you click, you can all you have to do is click the little arrow if you want to hear all of the testimonials. It takes about 10 minutes. The union article about patient-centered language is also one of the resources there, as well as a brochure explaining it a little more, identifying some additional language. The pledge form. If you want to take a picture, and there are the resources to do that and send it to Heartland, and all this can be found, and we really hope that you'll visit our website and participate. This is another testimonial. I'm just going to go through this one again really and let this particular woman speak for herself. We just spent yesterday at a memorial for this nurse, this healthcare worker with tuberculosis. She was really passionate about the Stigma Project, and although she had served others her entire life, one of her last acts of service in giving back and making a difference was participating in the Stigma Project. And yesterday was a really difficult day for all of us. So our center has issued this challenge. We're so excited that the Global TB Center has allowed us to participate in this webinar and encourage you to take this challenge with us. Think about what's holding you back from taking the challenge. It's just a click on the website, and then you have to type in a couple boxes, and then you're done. And we really hope to get many of you participating today to go to our website and add your voices to ours. You'll find the ability to you'll see me here with the pledge. You can download and print that pledge and take a picture of yourself and send it to us. And if you'd like, and we'd love to be able to put your picture with all the others that we have. If you just want to sign the pledge card, just fill in these couple boxes and one click and it will get to us. So we really hope that you'll do this and join us in committing to using language that is patient-centered, appropriate and sensitive, and represents the dignity of people with TB and their families. You might notice that I didn't list a lot of words. Mike had 5 words listed. I mentioned perhaps 5 words as well. I think we have to be really aware of not only the words that have already been identified today, but as we interact with individuals and our patients and their families, of what words may be hurtful to them. Not only should we be aware of multiple things that may be stigmatizing, but constantly aware of language that may be hurtful. Some of our patients identified not liking to be referred to as a case, but it will, I think if we're just aware and cognizant that we can determine if language is hurtful to our patients and maybe add to the list. I know there's an effort right now to identify language that is stigmatizing and or hurtful, and I think terms will be added to that as that work group continues to identify language. One of the first groups to accept our challenge was the San Antonio Metro TB Clinic, probably because they work so closely with us. Dr. Lisa Armitage and myself are the clinicians at that clinic, but this group of individuals from outreach workers and administrative personnel and nurses and DOT workers really just were so enthusiastic about this campaign. And although they said, one of the individuals said, I've been using this language for a long time and I may not get it right all the time, but I commit to try. And this person is so enthusiastic and really is embracing this campaign with her heart and soul, and it's really encouraging to us. At a national level, the Global TB Institute has signed on, the Mayo Clinic and the Curry Center have joined our efforts, and we encourage hope for more participation. And you can think, what can a national training center do, or what can a training center that isn't even a TB center or is part of a state or a local public health department do? Well, one of the things you can do is to ask speakers to eliminate stigmatizing language from their presentations. You can do it with a letter. You can do it verbally. This letter is on our website if you want to use any or all of it and just kind of make it your own. We'd encourage you to do so. You can commit to eliminating stigmatizing language from the educational products you develop. And most importantly, probably you can teach participants in your training courses about the negative effects that language can have, and we can encourage them to make sure that moving forward that they also eliminate stigmatizing language from their vocabularies. And we often have the ability to get brand new TB workers into our training courses, and so we can grab them and get them aware before they may have some bad habits that have developed. At a state level, the state of Kansas Department of Health and the New Mexico Department of Health have also pledged to join our campaign. At a local level, we noted that the San Antonio City Chest Clinic was our initial acceptor of our challenge, but now they've also become a challenger. This is Tommy Camden, who's the TB program manager, and he has challenged recently the Austin City TB Clinic, and Dr. Mary Ann Rodriguez has accepted that challenge. So we hope you're next, and if you've already accepted our challenge, we hope that you find someone to reach out and challenge. If you'd like to post challenger, an accepted challenge on our website, we would love to have you do so. And again, I want to thank the Heartland National TB Center staff and the TCID patients who have truly made a difference. It really made this campaign possible. It involved hours of their time, their ideas, their energy, and their work that allowed us to make such a powerful impact. And these are just a picture of a few of the few of the participants at the national conference that signed our pledge and took their picture. So we want to thank all of them as well. And that concludes my presentation, unless there are some additional questions.
Thank you very much, Barbara. I think there was a moment of silence there because I have to tell you that I think your whole talk just really made me think about other places in my own work where I could do much better at stopping the stigma. And I know there are 165 attendees on here, and so on the webinar today, and I hope that there'll be at least 165 more signees to the website. I'm going to go ahead and move on right now to Jigna, and then, as I said, we'll all take some questions at the very end. So I'd like to pass the microphone over to Jigna now to talk about Language Matters, the Power of Words.
Thank you. Can you hear me, Jane?
I can hear you, Jigna. Thank you.
Oh, okay, thank you. It's the first time I'm presenting on a webinar, so I'm not confident of my technical skills yet. Thank you. And I also want to thank you, Jane, for that kind introduction at the very beginning. So thank you very much. I'm so thrilled to be a part of this dialogue, which I think we all agree is long overdue. And I want to take a moment to commend Global TB Institute, Heartland National TB Center, and my friends at Treatment Action Group for their leadership in this effort of changing the language of TB. I'm one of the millions around the world whose life changed because of a single diagnosis. Many of you already know my story. In 2006, after my chance diagnosis of pelvic TB, which left me infertile and ended my hopes of motherhood, I began dedicating my efforts to raising awareness around TB issues that affect TB, particularly from the perspective of someone who was directly affected by this disease and its aftermath in my life. And we all agree that language matters. It impacts how we think about ourselves as individuals within our families and within society. When I was receiving treatment for my illness, I really hated being called a TB patient. It just made me feel that, for some reason, it made me feel like that the illness was somehow bigger than me and that it was the bacteria in my body which was more important than who I was. And to the date, it's the word TB patient drives me crazy. And during the course of my time as a TB activist and an advocate, when I've been invited to present at medical conferences, I've been routinely introduced and referred to as a TB patient. And again, this label just would drive me crazy, but I have just been too intimidated to protest against it because, and I know this is unknowingly, but the people who were giving me this label were the people who are highly respected and celebrated experts in the field of TB, and many of whom I admire greatly. And I have tried hard to come to terms with this label, but every time the word TB precedes me, it chips away at what I think is my true identity. Every time I was introduced as a TB patient or a former TB patient, I just always wanted to shout out and say that I'm really more than a TB patient. I want to be seen as a multidimensional individual rather than, to be reduced and defined by a disease. But sadly, throughout my years as a TB activist and advocate, I've been able to achieve very little success in persuading experts to discontinue using such labels. And for that reason, I'm particularly thrilled and encouraged by this webinar and the opportunity to share with so many attendees. And also, I want to take this time to remind everybody who's attending, who's a part of this webinar and listening, that when a person is diagnosed with TB, there is bacteria within his or her body. A TB diagnosis does not mean that the person is now defined by this bacteria. And But for many years, the language of TB has intentionally or unintentionally marginalized groups and individuals affected by this disease. But I think that we all agree now that the time has come to reframe the language around TB in order to empower rather than alienate those that have been affected. Much like TB treatments, the language around TB has changed so little in many years. And as I found more historical, medical, political, and scientific background about TB, the more I realized actually that experts rarely referred to those who are at risk for TB as a collective we, but rather used a very distancing they or them. And I always felt that there was such a subtle and a hidden message behind the words when those at risk for TB were referred to they or them, and I felt that it always perpetuated the stigma, because to me it sounds like that not everybody is at risk for TB. It's just a certain group of people or people who look like a certain stereotype are going to be affected by TB. And so I think that we really need to reroute the language around this disease and need to avoid using stigmatizing words. So instead of saying victims, we should be using positive terms such as persons affected by TB, and use us and not they or them when signaling who is at risk for TB. Because when we say that TB affects everybody, then really we should be talking, and even the medical community should be talking as a collective we rather than they. Language shapes our world, and choosing empowering language over stigmatizing words will really help protect everyone from the risk of discrimination. Those affected by TB discrimination are really penalized in so many ways. And one of the most powerful ways is through media reporting. Media has such a huge effect on the changing tide, can have a huge effect on the changing tide of the stigmatizing language. Words such as hunt and victims, they punish and diminish those who are already bearing the brunt of this disease. Frequently, those affected by TB are seen as individuals to be feared, someone who's frightening, immoral, perhaps a deadly criminal, and in some ways not even human. I came across this article from The Guardian from 2014 from South Africa, where related stories on the same page about TB also featured a story about how to capture an escaped crocodile, or deadly criminals who were shooting police officers. And this is just a way to demonstrate that when news media sensationalizes TB and the stories that surround and the images that surround these stories, they really create negative effects. It reinforces the discrimination. And people who are suffering from TB are then portrayed as escaped criminals or that need to be hunted down. But sadly, I've seen very few, or it has been a rare instance that I've seen that professionals or medical experts or scientific experts speak up openly or publicly against, these sort of injustices against TB sufferers in the news media. And those that are hunted are often left out in the cold to really protect their humanity by themselves. And I think efforts such as this webinar, it is my hope that will inspire and encourage those of you who are working in the field to speak out when you read or see something that dehumanizes the people that you treat and serve. So language is constantly used as a tool to effect change. We think about our words and how they affect others. We reflect on words others use and what language is damaging, what language is constructive. And I also feel that language has mobility, does not need to stay static. And words that have been used in the past around TB are really not relevant anymore. And like TB treatments, how we talk about TB and how we talk about those who are affected by TB needs to really be updated and brought into our modern era. Stigmatizing words such as defaulter, suspect, non-compliant, they all really need to retire immediately from our vocabularies. And similarly, labels such as TB patient or TB suspect really are undignified and they are judgmental. And I also want to draw attention to the word infection or its derivatives. For example, when somebody is referred to as infected, it's really a very derogatory way of saying it, because oftentimes not in academic or scientific or medical world, but in the society at large, when words such as infection or infected is used, the images that conjure up in imagination is really about corrupt, dirty, or tainted, and anything that is associated with an infection is automatically devalued. So when the word infection or related to that is used, I urge that everybody be conscious about the context in which it is being used. Historically, I feel that the language around TB has always put the individual last. I think there is an urgent need to change that. We need language that puts people first. When we use language that puts people first, we acknowledge others and ourselves as fellow human beings. For example, persons affected by TB. This puts the individual first rather than a TB patient, which puts the bacteria first. And similarly, by talking about persons as individual humans rather than people as a mass, we come together and we affirm and emphasize our shared humanity. And we acknowledge that our identities, just as the identities of all other human beings, are layered and evolving and more nuanced. And lastly, as we talk about finding new words, more appropriate words and respectful words, I also want to highlight that while we are doing that, to stay away from acronyms. Please do not create acronyms for those who have been affected by TB. We are actual persons, and we'd like to be referred as such. I think acronyms dull the awareness of that person, and it only adds yet another label. So as we are working towards new language that creates equity and respect for all people affected by TB, I think acronyms is a good idea to stay away from. Because I don't want to have another webinar where I'm talking about, well, this acronym is now not dignified. So I'd rather say it first out. So a couple of questions that came to my mind while I was preparing for this was that who is going to really be responsible for changing the language? As Mike said, Mike showed us the TB patient's charter, and that was something I was given very early on as I started my advocacy efforts. And so when I was preparing for this webinar, and I was thinking, well, now who's going to be responsible for all this? And as history has shown, most of the responsibility ends up being on the shoulders of those who already are suffering. And so I wanted to clearly list out some of the folks that I think need to share the responsibility equally. And, the way I see it, media, medical professionals, health advocates, they all have a role to play in changing the language. But, and I also think that change is going to be propelled when those who are experiencing or have experienced TB are an equal partner in this process because they are best suited to create this manifesto. People who have experienced or experiencing effects of TB are really in a better position to tell the public what stays and what doesn't stay, and they need to be involved in these decision-making. A lot of times, people who are affected or have been affected by TB are really added to conferences or meetings as really an afterthought. And I think that they should be the first in line in the panel of experts. So I think having an equal seat at the table is crucial as we move forward into the modern era of TB. And the second question is, what are we going to do? What do we do? Immediately what we need to do is, of course, stop that stigmatizing language and the blame game. Putting the blame squarely on the shoulders of those who are suffering from TB is unfair and unjust. And we need to recognize that people affected by TB are the best suited to creating this new language. And we must commit to bringing multidisciplinary scientists, including social scientists, and all other experts to find the most effective solutions that work for this era. And lastly, I want to say that stigmatizing words are the enemy of hope when people are really trying to make a change in their individual lives or in the broader public life. And using imprecise language to describe those affected by TB is a guaranteed way of fostering fear and discrimination. We need support and sensitive language, and that is going to be critical as we all work towards achieving a TB-free generation. And the three things that I would like to leave everyone with is that no one can control the air they breathe, but we can all control the words we use. And as Emily Dickinson writes, I know nothing in the world that has as much power as a word. And lastly, if we can find a way to change the words used to form the language around TB, we can perhaps end the stigma that plagues TB. So thank you so much for listening.
Thank you, Jigna. I think you really brought this to a very personal level for all of us, and I appreciate that. We now have a little bit of time for some discussion and questions for all of the presenters. If you have a question to ask over the phone, please press #6. Say your name, where you're from, and your question. And we're also we've been monitoring some of the Q&A boxes. So if you prefer to write a question, please feel free to do it that way. While people might be unmuting, I'm just going to start with one question. And Jigna, I think this will come back to you. I was struck because I have to say I've used the term TB patient for a long time and never really thought about that as defining. And so that was very helpful when you mentioned that. But then I was struck by your comments about a sense of disempowerment about how to say, don't introduce me that way. How can we, as health professionals, help to empower our patients to be able to point that out to us when we say words in the wrong way?
Jane, the first thing that I want to, say is that there has been a real absence of involvement of people who have experienced TB in their own treatment or in their own advocacy. And it's only in the last few years that I have seen more and more providers and healthcare officials really put in a conscious effort of seeking out individuals who want to talk about their experiences. And I think that provides a level of comfort. I know that I've had, when I first started talking, it was petrifying, and that is why I could never really say much in front of a room full of people, who are giants in this field, and then there's me. But over the last few years, I've had a few peers on the stage or on a podium alongside with me, and I have felt that has provided me with greater courage and confidence to challenge or point out or even collaborate with professionals in the field. So it's hard being a patient to tell your physician or your provider that don't call me something, because we are looking at you for that leadership. And for years, although I never liked people calling me a TB patient after I had finished my treatment, but I also introduced myself so many times as a TB patient because I felt that's what I'm supposed to do. And so I think that the change will really come when you have more voices, when you're able to bring more voices to the table. The confidence will be much greater, and there'll be more voices to, help educate the medical community on what changes need to be done. But it's hard when it's just one person or two people. Mm-hmm. And having seen Barbara's presentation and the number of people that she's been able to, publicly acknowledge their TB experience, I think perhaps Barbara might be able to give us clues onto how she convinced or what she did to make people comfortable, the people she is caring for comfortable in speaking out publicly.
Barbara,
so that is my answer. Yeah.
Oh, thank you. Barbara, do you have some comments about that?
Well, first of all, I want to credit the members of the Heartland staff that actually individually, each person at Heartland worked with one of these people. And sorry, I'm trying to use the right language here. And thank you, Jigna, for identifying that the terminology TB patient is bad. And I tried many times in my presentation actually to talk about persons affected by TB, but sometimes it's just hard to change old habits when you're old. But so we had a number of individuals who are hospitalized here with tuberculosis, and we went to our volunteer services and kind of put out a call to who might be interested in working with us and participating in our campaign. And we had some initial interest, and we talked to a number of people, and some of them wanted to just hold up a card. You notice the one man who held up a card over his face. He didn't really feel comfortable showing his face, but he worked so hard on the project. And increasingly, he may be coming around to, just as you noted, Jigna, that having others around you speak out makes it a little easier for you to do so. I understand now that he may be willing to do more of a video. But I think it's just the courage of the individual that is willing to do it. It is hard. As a physician, I always tend to be protective of those who are entrusted to my care and not want to, offer them up to do something that I feel they may be uncomfortable with. So some of it is just my own personal, maybe overprotectiveness of individuals. And if I ask more people, that maybe more of them would be willing to volunteer. And also, I think as they see these collective examples of those who are willing to speak up, that it gives others the courage to do so. But it is a tremendously stigmatizing disease, and when I I first see someone in clinic, they're often shattered with the diagnosis. Almost everyone is shattered by the diagnosis, and just the tremendous stigma that exists around the diagnosis, let alone the language. So I'm not sure I have great answers, but I think as more people have the courage, that it'll encourage more and more people. And so, Jigna, you've been such a pioneer, and I'm so respectful of you and the work you've done.
Thank you all. I think it's the one unfortunate message I have to convey to people is that we're toward the end of our time. So I'm going to have to start to bring this to a close as the moderator. But I just wanted to highlight a couple of things that I wanted to take away. And that is that from Mike's presentation, I just really liked the idea that the first entryway to human rights awareness is through active listening. Barbara, when you were talking, I always bring that the TB guidelines, and I'm reminding people about what the responsibility for successful treatment is. But it made me aware, listening to you, that I don't always sit down with the patients in those first visits and tell them what I'm responsible for, and that may be helpful. And Jigna, I think you also have helped to highlight to me the importance of empowering all of our partners, and with the major partners being those we care for. I'd like to just throw down one challenge, and I've thought of at least 3 ways I could actually try to further the Stop Stigma campaign, and I'm going to put them out there publicly so that I hope that the people on the line will each think of something they can do. I'm just putting my lectures together for the beginning of the academic year. I'm going to put this into all of my lectures. I'm planning to send the campaign to the Rhode Island Health Department this afternoon when I get off. And for once, I'm going to try to use my Twitter account at the union to bring some awareness to the Stop the Stigma campaign. And I hope that we can inspire each of the people on the line to think of at least one thing. The Heartland is requesting that you take the pledge, and you can find it at this website. And I hope that by the end of today, there are 130 more signatories to this pledge. Finally, the New Jersey Medical School Global TB Institute provides medical consultation services. You can call 1-800-4TB-DOCS with any questions requiring medical consultation in the Northeast region. This concludes the conference, and thank you for your participation, and I hope this has been as thought-provoking for you as it has for me, and thank you for all of our speakers and the TB Global Institute.